Respiratory Part 1. Here's your objectives. Respiratory patho, the trachea, the mainstem bronchi, the bronchioles, and then the alveolar ducts and the alveoli. So diagnostic test. Main blood test that is done for this is ABGs. Remember, if someone's hypoxic, they're going to be in respiratory acidosis. If somebody is hyperventilating, they're going to be in respiratory alkalosis. We like to know what the H and H is, especially if someone's having a hard time breathing, to make sure they are not also anemic. D-dimer is specifically for a PE patient if we're trying to rule out a PE. Blood cultures for sepsis patients. Remember, a sepsis patient, if their temperature is going up and their blood pressure is going down, check their pulse ox, because their pulse ox is probably dropping and they're probably about to be an intubated patient, and we get into that in part 2. Chest X-ray is going to tell us a lot of what's going on inside the chest wall. CT scan for more soft tissue and organs. Pulse ox. I think you guys know what a pulse ox is at this point in time. Pulmonary function testing. 3 things to remember for a patient that's going into a pulmonary function test is they are supposed to hold any bronchodilators for the day before the test. They are supposed to stop smoking at least 6 hours before the exam. And the client needs to be coherent and be able to follow commands. And we'll get more into the entitling and ranges when we talk about intubation on part 2. So diagnostic tests. Bronchoscopy. This is where we actually use a scope and go down and you can visualize the lungs. For bronchoscopy, the patient will be sedated, and we can do this procedure either in the OR, or if the patient is already intubated, we can do it in the ICU at bedside. We're able to get sputum samples, we're able to visualize structures, we're able to get biopsies doing a bronchoscopy. Thoracentesis. Thoracentesis is we're going to aspirate air or fluid from the pleural space next to the lungs. Patient position for this is sitting up at the side of the bed, preferably leaning over a bedside table that is locked so it can open up the chest wall there. All right, let's go to pulmonary embolism, a PE. Patho from a PE. It is a blood clot that typically originates from a DVT and travels up to the lungs. Big risk factor for a PE: immobilization, spinal trauma, smoking with on oral birth control, pregnancy, AFib, and there's quite a bit of other ones. Sign and symptoms of a PE. The four most common symptoms of a PE is chest pain, shortness of breath or dyspnea, hemolysis, and tachycardia. Those are the 4 most common ones that we see. Treatment for PE. Typically, we start treatment for PE and we use heparin. Heparin is the most common treatment. When we are giving heparin, we do have to worry about any interactions if they're also on warfarin or Levinox. And make sure you are watching the platelet count when the patient is on heparin. If the patient has a low platelet count, we may be having to treat with something else or give a platelet infusion. Nursing care, especially non-pharmacological nursing care, the patient's not going to be able to breathe well. So as a nurse, we should acknowledge the fear, right? Let them be afraid, but but we also keep them calm. If the nurse stays calm, the patient has a better chance of staying calm. And then we're going to do things to try to distract the patient. Meditation, TV, music. So those are 3 things that can be utilized quite readily, and we can do it right in the room. And we don't have to bring anything in outside of the room. All right, chest trauma. So 25% roughly of traumatic deaths do result from a chest injury. So a pulmonary contusion, which can result in rib fracture or flailed chest, a pneumothorax, we're going to be watching for ABCs here. The lungs could be bleeding or bruised. See this the most in MVAs. It's potentially life-threatening, but oddly enough, it can develop slowly because it's a bruise. A bruise isn't going to show up right away. Rib fractures. So we don't typically do a whole lot with rib fractures except teach the patient the deep breathing and coughing, which is going to be very, very uncomfortable for them. Main complication is pneumonia because they're taking those shallow breaths. They could have a flail chest. Remember that paradoxical effect we talked about in MedSurg 1? Where instead of the chest just rising in and out when they take a breath, this patient's chest moves at a very erratic motion. While this isn't life-threatening, we will be watching for any types of difficulty breathing or pleural pain that could suggest an infection process. Pneumothorax. If a patient has absent breath sounds and they have not had surgery to remove a lung, chances are they have a pneumothorax. And a pneumothorax can only be fixed by chest tube placement. Tension pneumothorax which can result in the pneumothorax either not being diagnosed or it is developing very rapidly. So the lung is pushing down rapidly and there is a great deal of pressure pushing on that lung and it moves up and then pushes up on the trachea, causing a tracheal deviation, which is life-threatening. And if we do not immediately put a chest tube in or at least aspirate the chest cavity, the patient will die. There is no airflow coming in. Hemothorax. Hemothorax is where there is blood in the pleural space, typically from some sort of trauma. So for a chest tube with a pneumothorax, we have to make sure that there is not a lot of fluid coming out fast. So initially, if we had a 1,000 milliliters initially out, that would be dangerous and we need to clamp the chest tube and go into surgery. That means there's an active bleeder. The physician needs to know about that because the patient is actually bleeding out internally, and even though we're collecting it, not going to be enough. We're going to have to go in and cauterize whatever is making all that blood in the chest tube. This also can happen from a pulmonary contusion. So we have to look for the four main sign symptoms of a pulmonary contusion. Hematitis again, so coughing up blood. Crackle slash wheezing. You're going to see their pulse ox drop, and they're going to be breathing very rapidly. They're going to be practically hyperventilating on you. They also could have a respiratory issue where they get the intercostal suprasternal retractions, where you can, when they're trying to take a deep breath, you can see the ribs coming through, and they're using all those accessory muscles. This is a very high priority patient. This patient is about to go down on you, and you need help. So the different chest tube sections here. So a chest tube with continuous bubbling in the water seer chamber should be clamped and checked for leaks. So leaks in the tube connected to the body, there's probably a leak somewhere. But if there is no fluctuation in the water seal chamber, check the tubing to see if it's clamped or kinked. So those are the two big things that you're going to be doing chest tube assessments on. And just remind the patient it's actually normal for them to feel the chest tube inside their thoracic cage, especially on inspiration. If the tube were to accidentally get pulled out by the patient, or accidents do happen, remember we use Vaseline dressing that's open on one side to cover the wound, so the air from the outside of the body can't get sucked into the inside of the body when they take a deep breath.